Okay. So thank you again for coming here tonight. We heard from Louise. I could go on and on about all the science, but thank you for what you said. And one of the things that my marketing person who's seen me do this talk with PowerPoint and be all professorial wanted to make sure that, George, does anybody come to your office and tell you, when you ask them, what's your chief complaint or why are you here to see me? They go, I hear you give the best osteoporosis and cardiac protection of menopausal woman can have. No. They come to see me because they want to look better, feel better, lose some fat, and have more sex. Well, that's pretty much something I can promise. But along with that comes osteoporosis protection, comes cardiac disease protection, comes muscle mass, comes the ability to finally lose weight when you go to do that workout. Your workouts will finally work for you again. But along the way, these are just the benefits while you're looking good, feeling better, losing fat, and having more sex. We talked a little bit about those horse hormones and synthetic hormones that led to all the fears that men and women have about hormones. That's not what we're talking about. We're talking about human hormones given back at physiologic levels, just putting the air back in that leaked out. And that's what I'm trying to achieve. Excuse me. Let's talk about heart protection. The biggest risk a woman has for having heart disease is, diabetes. The second biggest risk is going through life after menopause, not having our hormones replaced. It's a higher risk than hypertension, than smoking, than having hyperlipidemia, high cholesterol levels, all of that. Not replacing your hormones is what causes the heart disease in females after menopause. Before menopause, women might have heart attacks, but nothing to the degree after menopause. After menopause, women stand the same risk of having a heart attack as a man her exact age. Nobody ever thinks about that. Osteoporosis. Did anybody in this room stop eating calcium-rich foods when they turned 45? But your doctor kept giving you, calcium, saying you have to take this for your bones. Why? You didn't change your diet. What you stopped doing was making estrogen and testosterone. And these are the hormones that tell men and women, because men can get osteoporosis, but men have just such higher bone densities to begin with that it takes a lot longer. But it's the hormones that tell the bone cells to lay down bone material. Once again, it's a hormone imbalance. It's not a calcium deficiency. Muscle mass. Men, when they get older, have a little bit of testosterone still around, and then they can go work out, but they have to work out so much harder to get the same results as they used to. When women go through menopause, they don't have testosterone. And it doesn't matter how hard they work, they don't see results. If you don't have testosterone around, along with resistance training and some protein-rich foods, you can't put muscle on. And there's a lot of personal trainers who send me almost all of their clients above the age of 45 for two reasons. One, it's mainly business. That person's going to get to a point where nothing the trainer can do can help. And that person's going to get frustrated and quit. Trainer loses money, but more importantly, that client, that patient, that customer loses the benefit of exercise. But until, and this is usually women, until they put on some testosterone into the regimen, they're not going to be able to put on muscle mass. Just as Louise was saying, there was a patient that saw me about a year ago here. And she's 61-year-old. She's a 61-year-old nurse. She's very attractive to begin with. That was before she ever came to my practice and got on any of these hormones. And she said to me, Dr. Ibrahim, this was in June. She goes, when you got to that slide about make your workout work, that hit home because I was so frustrated. Nothing was working. She goes, well, let me tell you something. I have a two-piece bathing suit that I have in the top of my dresser drawer. It's been there for about 2.5 years. Tags are still on it. She goes, well, I tried it on last week. It fit. I pulled the tags off. She goes, I'm going to be wearing that next week when I go to the beach July 4th. And I go, you go, Grandma. Walking down the beach, the two-piece bathing suit. But it works. It does work. Skin. Everybody remember, if you're a woman when you were pregnant, that glow women get during pregnancy? Well, that's caused by human hormones. That's caused by a very high level of estriol and progesterone. And estriol is a type of estrogen that they're able to mix here into a cream. That the results are fantastic. Pore size. I never knew women cared about pore sizes, but apparently you do. And estriol is what's going to help build out collagen. All the over-the-counter stuff you use is there to protect your skin, hydrate it, moisture, but it cannot make your skin, your fibroblasts, lay down collagen. And that's what, some of the hormones that, I do will help you with. Louise talked about sleep. It blows I get more hugs from women who sleep through the night than anything that I do. Progesterone, when taken in the manner that I prescribe it, has an effect on the GABA receptors in the brain, and a woman who sleeps through the night is a much happier woman. And husbands that have women who don't sleep through the night are much happier when the woman sleeps through the night. At the end of the day, you're going to look better, feel better, sleep better, lose some fat, have more sex, but you get to have all these benefits back with it. Men. What's the hardest thing with treating men? Getting them in the door. We offer a money-back guarantee on men. All you have to do is get a man in the door. They only have one hormone that's really going to be of issue, that's testosterone. It's finding the right level. 100% of all men that are over the age of 50 have less than 50% of the testosterone they had when they were 22, because that's when men mostly peak. When a man's 60, he's down to 1/3. So to the women in here, but most of the women here have, or a lot of them have men with them, but to the ones who don't, and your husband or your partner says, I don't need any of that stuff, while he's falling asleep on the couch after dinner, 9 o'clock movie, that's never going to happen. Is he getting a pot belly? Is he getting frustrated with going to the gym? Is he irritable? The movie Irritable or Grumpy Old Men, that's just low testosterone. That's all that movie was about. Men lose their testosterone at a much more gradual rate than women lose their hormones. Women are pretty consistent until they go through menopause, and then it can be like being slammed by a freight train. But men lose theirs from 1% to 4% a year beginning at the age of 22. You compound that over 20, 30 years of time, and by the time they're 50, it's half. So every man who's 50 years old has less than half, or just around half of what he had at his peak. And every man at 60 has 1/3. I'm sorry. If you go see your primary care doctor and he gets a testosterone and he says it's fine, what he's looked at is what's called a reference range. A reference range encompasses 97.5% of the population. That's if you marched 1,000 people through my office and took their blood pressure, you'd have blood pressures from 60/40 to 280/200. But what's optimal? What's optimal is right, maybe 120/70. My point is, what's an optimal testosterone for a man? If you don't have a libido, if you're having erectile difficulties, if you're sitting around falling asleep after dinner, any of the symptoms that are on one of the smaller flyers that I gave you, that's probably the lack of testosterone. About the only thing that decreases a man's libido is too little testosterone and or psychotropic drugs like some of the antidepressants. And that can rob a man and a woman of their libido. If a man's libido is not where it used to be, it's testosterone. And don't let primary care tell you that your testosterone is okay. They're not looking at what's optimal. And I can understand fears of prostate cancer and the recent ones with cardiac disease, but I can give you study after study after study and show you where these fears are misplaced and they're based on erroneous studies. Weight loss. We do a program where we offer some vitamins and amino acids. They're called lipotropic vitamins, and they're phenomenal when it comes to weight loss. I'm not going to speak much tonight about growth hormone, but we have a program that enhances growth hormone production, and it's natural. It's not growth hormone itself. It's called growth hormone releasing hormone, and it promotes your body to make its own growth hormone, and it's a much more natural feedback mechanism. We talked about the face creams. We talked about the estrogen being one of the major female hormones. We do estrogen in all sorts of different methods: creams, patches, and pellets. And I talk to patients individually about these things. So I'm not going to get into it specifically tonight because what you might need is different than the next person. Testosterone, we also do that through the skin, typically creams or pellets. And then progesterone, I can do that through the skin, but it's usually by pill form. Cost. Louise was talking to you about that. The established patient typically doesn't spend more than $100 a month. The first year, yeah, that's going to be more expensive. It all depends on the type of hormone replacement you need, what methods you want to do it. But at the end of the day, it literally, for the vast majority of patients, is less than a cup of Starbucks coffee a day. And if you think about what's your cable bill and how many of those 400 channels do you actually watch, or You know, do I really need to get my pedicure done in February? These other kind of things that you could shift some costs at the end of the day, even if you don't get any insurance reimbursement. I can't tell you how much better most people you're going to feel. Insurance, almost every insurance company will reimburse you for the labs, if not in whole, at least part of, but I have no way of knowing. I mean, and everybody's plan changes. I can't tell you what your program is going to cost because everybody's plan is individualized just for them. And if you can pick up a phone and call a practice and ask, what's it going to cost to get my hormones replaced? And they can tell you over the phone without ever having seen you, you have to wonder, how can they do that? I mean, you know, if you call up, they tell you the same price as they tell you, you know, there's no individualization to that. And at my practice, everybody's individualized. At my practice, you'll always see a physician, and that's me. There's not a problem with seeing nurse clinicians and physician assistants at all, unless there's no physician oversight. And some of the practices, you know, rarely, if ever, will see an actual physician. We have shopped around, and we realize that our prices are about the same as everybody else's. And so, you know, I don't want to be a Walmart experience. I want to be a value experience. And that's what I'm here to offer is, you know, the value of having, you know, a Duke trained surgeon who's now doing hormone replacement, who's done a fellowship, be your doctor and your contact person when we get you tuned up. And that's a lot faster than I normally would talk, but I want to get this in while we still had it being filmed and let y'all start asking some questions of me and then of Louise. Anybody have any? Okay.
What is the difference in accuracy between, say, a saliva assay and having it tested with your blood?
Okay, what's the difference in saliva and blood testing, basically? Doctors versus pharmacies. That's my main difference. There are arguments to be made against and for both of them. Just physicians are much more, much more versed in blood work, because that's what we learned during residency in medical school. When it comes to hormone levels, I've just learned to use blood work as my method. I mean, and there are some physicians that do saliva, but
well, I just read that saliva is more accurate.
It depends. It depends on what the hormone level is. It depends on which one you're looking at. But overall, no. I mean, there's a doctor who's well versed in this can use the blood work perfectly, and Ms. Baker can tell you about that. I mean, she's been. Excuse me about that. I did not mean to use that. Can tell you that it depends on the physician doing it, and I could talk hours on which one's better and which one's and give you just as many arguments against saliva as I can for saliva, and I can argue just as many arguments, you know, and I can be on the saliva camp as well. And there are certain labs that are, you know, much better with saliva, and some that really don't make a difference. Okay, anybody else? I couldn't have answered that many questions already. I've done this enough times. More. Yes.
Is there a time limit that is better or worse that you should stay on hormones? I mean, is there like 10 years or?
Is there a time limit? I plan to do it until I'm dead, as does my wife. She's a physician. She's a cancer doctor as well. All of the benefits show all this protection. You know, why would you give up the cardiac protection? You know, I mean, if I'm miserable at 85, I might stop it. But if I'm liking the protection, why stop it? You break your hip at 80, good chance you're going to die, you know, with the nosocomial infections. You don't want to break your hip. So I don't plan to stop. People say, well, what are the long-term studies? Yeah, well, these have only been out 10 years. I say life is the long-term study. I mean, these are the same hormones you were making from puberty. And you made them from puberty until menopause, if you're a female. And you made it from puberty to now, if you're a man, you're just making far less of it. And so, you know, basically we're just outliving our gonads. There's a new theory on aging, neuroendocrine theory on aging, and you know, we were asking ourselves at one time, well, do our hormone levels go down because we age? And now we're probably saying the exact opposite. No, we age because our hormone levels go down. If you took a 28-year-old woman and took her ovaries out, and I know this because I was the medical student that did not put the estrogen patch on the patient in the recovery room. I came back into the recovery room about 45 minutes later after the next case, and this woman had woken up and she's screaming. Why? Because she went to sleep prior to the operation feeling like a 28-year-old, and she woke up feeling like a 65-year-old woman. it's because her hormones have been cut like that. So, I plan to do it throughout the aging process because I don't want to feel that way. Any more for Louise?
How often do you have to check in with your office?
Right now, I'm kind of on every 3 months unless something else comes up to get the blood work done, because I've gone to use the method of the pellets. So the medicine hormones are put in a little pellet that's injected under your skin. And it's much more convenient than rubbing creams on every day, because I did that too, where you rub the creams on here, you take a pill, you put a patch on. Oof, it's a lot of work. And so for me now, it's every 3 months, unless I want to come back to talk to him about other supplements or whatever. So.
And everybody's different. Some patients, prefer to do the creams and patches, and you can always change. And that's, I offer all of the different methods. You're not roped into just always doing one thing.
What about sublingual? I've heard that some hormone replacement is done.
I'll do some sublingually. I don't like to do testosterone sublingually, especially in men. But I can do that if that's a person's preference. I really don't like doing estrogen sublingually because you're going to swallow some, and going through the liver with estrogen and testosterone is unnecessary, and it's not physiologic. And why do that when you can do a much better method? My goal is to treat every woman the way I would my wife, and I would never give my wife oral estrogen testosterone.
Really?
Yeah, I wouldn't, ever. When estrogen goes through the liver, some of the cytokines and coagulation factors that are produced are why there were problems in the horse studies. It's not nearly as bad with human hormones because it's not as powerful as the horse hormones, but that horse hormone medication that they gave in the Women's Health Initiative was given by mouth. Your ovaries don't push all the hormones straight through the liver. It disperses it throughout the body. When you take a pill, it goes straight through the liver. And it really kicks the liver hard. And there's no reason to do something like that. If you can do it safer and better, why would you do it that other way?
I realize everyone's different, but typically, how long does it take before you get the right mix, and then how often do you have to change it up?
Okay. Typically, it was asked, how long does it take to see results? What I tell every patient when I'm talking to them the first visit, I go, I so hope I knock this first pitch out of the park. And probably a good 85%, I nail it right then. But you never know. And I have to remind the patient, you've got to give me feedback. If you let me know any issues, any disappointments, anything that's going on, we can adjust. And it might take 3 months, it might take 6 months. In rare cases, it could take 9 months. But I'm going to, under promise and over deliver. But the vast majority, 3 months. And I'll probably say the vast majority after the first visit, but usually by the second visit, we're pretty close to the bullseye.
So to see results, and then to also feel like you've got the right, the right balance.
Yeah, and people always say, well, what's my number supposed to be? Oh, I don't treat the lab. I get the labs. I use the labs as headlights. I use the labs as guardrails to keep me from falling over the edges. But I use what you tell me as the headlights. Why would you treat a piece of paper? Because if you look at what the ranges are on what a woman went through in her life as far as her estrogen levels, it might be as low as 12. It could be as high as 4,000. What are you supposed to be, and what are you supposed to be? Everybody's different. Testosterone, the difference is enormous in where a woman feels her best place. And think about it, when you were having periods, you were all over the place. Well, because your levels were changing. And at some point in time when a woman was having periods, she really felt good. And there were times when she really felt bad. That's because that number is not the good number for you when you're feeling bad. I need to find the good where you like. And so I'm going to be asking you how you're feeling. And that's more important than what your numbers say.
Is that something that we can expect is possibly starting periods again?
Yeah, that could happen. You won't start periods, but there is the possibility of breakthrough bleeding. We can almost always fix that in no time. But yeah, that's always a possibility. I mean, and we're talking about very short-lived. You're not going to become 17 again, as far as, I mean, if I do my job right, So I'm going to wrap up a little bit of what I'm saying just so he can, end back there. But again, it all comes down to this. It's an individualized program that's less than a cup of Starbucks coffee a day that you will feel better. There's no question. You will sleep better. You will start to look better. You will start to lose fat. I don't use the word weight. I use the word fat because muscle weighs more than fat. And you might see the scale actually go up initially while you start to burn the fat, but that's a good thing. It's more muscle. And you have more sex, and most people are much happier. I've told you the red flags about practices that say they take insurance. Most of them, all they're doing is filing your insurance for you, but they're collecting the check. At my practice, you file, we give you the form, you file it yourself, but the check comes to you. So that's something to always remember. Very few insurance companies will cover hormone replacement. They might they'll cover the labs almost always. They usually cover some of my visit or apply it to your deductible, but that's just one of those things that most insurance companies don't do. And then lastly, one of the things when seeing a primary care physician is they're not getting paid for the hormone talk. So if your gynecologist is writing that prescription as she walks out the door, she doesn't have time really to micromanage you and see you back the way I do Louise, because she doesn't get paid for it. And you can't blame them for that. I mean, they get paid for a well woman's visit, but they really don't get paid to have you come back every few months and get adjusted on your hormones. And that's important to realize, because I'm not about to tell you that I can see you once and it'd be perfect, until next year when you come back and see me and I'll rewrite your prescriptions. No, it's going to take some time. And that's what keeps a lot of primary care doctors from really spending the time to do this, because you can't blame they're barely getting paid right now to begin with, and they don't get paid for it. So I'm going to break, let you take this. All right? Okay, and then what's the next step, or how best to get up with me? The easiest thing is to go to my website, and there's a button called Patient Portal, and you click on it, and it takes you to where you start entering your demographic information. Or you can go to a button that says Info, and we'll send you an email with all sorts of information. And then there's the phone number. But right now, that phone number is being switched around and put into a different phone system, and I can just tell you the easiest way to do it is just to go through the website while we get our phones under control. We're going to answer your email questions a lot quicker probably, because our phone system is a little bit messed up. So I thank everybody for coming out to see me. Again, it's George Ibrahim, Asheville HealthSpan MD. We're located near the Biltmore School. We are not in the Biltmore School, but we're right near it. And directions to our practice are on the website and everything. You've all been given a $50 gift card if you come to apply to your visit. If you tell me tonight, yeah, I'm ready to make a visit, have your secretary get up with me tomorrow, I'll give you a second gift card. Disclaimer, you cannot combine these with any other offers, and they're only good for the first visit. You will then be allowed to give other gift cards to friends. If they come see me, you'll get a credit, and your friend will get a $50 discount. But again, these cards are only good for the first visit. So thank you very much.